Dr. Muradov, thank you for being with us here on Best Practice. How are you today in Houston?
We're doing great. Thanks for having me.
You got it. I want to talk about joint replacement with you, obviously, because you're a joint replacement surgeon. And I'll give you dealer's choice. You're the expert. You want to start with the knee or the hip?
Let's talk with the hip and then progress to the knee from the top to bottom.
Perfect. So, with the hip and total hip replacement, people are looking for a minimally invasive approach, something that can allow them to have a quicker recovery with lower risk, continued reduced risk of dislocation. What's your approach to those issues? How do you approach the hip?
Yeah, so there's different ways to approach the hip, and no one approach is truly better than the other. But there are some approaches that come with certain set of risks, and the goal of the surgeon is to try to manage those risks based on the patient type. Some patients are going to be more risky to approach from the front, and some patients are going to be more risky to approach from the back. The advantage with me is I've done two fellowships, not one, on hip and knee replacements. And the European fellowship was very strongly flavored with the anterior approach or the direct anterior approach. The local fellowship here in Houston at the medical center was all posterior. In residency, I've done nothing but anterolateral approaches. So I've kind of done all approaches. And I kind of have a 360-degree view of what the hip is all about. I would say the staple for me right now is the direct anterior approach because I have found it to be the most stable. One in four hips that fail early, meaning the hips that don't survive for 20 plus years, like we expect them to, but the hips that survive that fail early, one in four fail for dislocation. And
Ah,
the direct anterior approach in my hands gets rid of that complications. So in 8 years, I haven't had a single anterior approach that I know in a primary hip dislocate. I did have two posterior hips dislocate, full disclosure. So it's definitely a more stable approach, and that's why I use it as the staple.
that's absolutely awesome. Just to be able to take dislocation off the table with the anterior approach. And the concept there, as I understand it, is by preserving all the muscle, the native strength of the hip is just stronger after surgery. And so dislocation is less likely. Is that correct?
Yeah, so when we perform a posterior approach, no matter how good you are destabilizing the external rotators, and you're also destabilizing the posterior capsule, which gives you intrinsic stability. Most of our life is spent in flexion. We're sitting down on chairs, facing forward with our booty on the chair, not bending backwards. So you are just logically more likely to dislocate through the back because of the way our hips position in space. So by not destabilizing anything in the back, by utilizing the direct anterior approach, you're less likely to dislocate. And it conceptually makes sense, and it's true in my hands. Now, I say in my hands because American surgeons have a tendency to use a direct anterior approach with the help of an assistance of a fancy table. So they use traction tables to help with the exposure during surgery. And the traction tables are great because they allow to make the otherwise physical operation less physical. They help the surgeon, but they come with a cost. And the cost is you do not get to fine tune the hip. So basically, it's very difficult to put a hip through a full range of motion when your legs are strapped in a boot and they're non-sterile and you're sterile. So surgeons kind of have different ways to get around it and try to manipulate the hip in the boot and see what the true range of motion is. But the advantage of doing the hip the way I do it and the way I learned it in Europe from Professor Corton is that my legs are prepped in, and I don't use fancy tables. So I'm able to range the hip through full range of motion, knowing on the table that no matter even if the patient brings their hip to their knees to the chest, they're not going to dislocate. And if they are with the trial components, if they are dislocating, it gives me the opportunity to adjust either the cup anteversion or their femoral stem position in a way that makes the hip stable.
Oh, that's really interesting. Now, you guys, how long do you require a cane or a walker after surgery? And if so, for how long?
Yeah, so my patients typically are asked, and they don't always comply, but they are asked to use a walker for the first week or two, or until I see them in the office, which is usually around 10 days when I look at the wound and take the dressings down. Most of them, I'd say probably 3 out of 4 patients walk in kind of carrying the walker, or they grab the
Yeah.
walker for the follow-up visit, just so I don't get angry at them. Then the reason I ask them to use the walker the first week is when you go through the front of the hip, a lot of times the muscles, the rectus muscles, and the muscles that are involved in um, flexing your hip and extending your knee are kind of deadened a little bit. And so it takes a few days for that muscle to fully become responsive. And that's a perfect opportunity to take a fall. So I tell patients, please have a walker in your hands. So that way, in case your muscle decides to give way, you have something to brace yourself with and not fall. Um, and this is more important for more elderly patients. Some of my younger patients just kind of disregard my recommendation and walk without any assistive device. But it's usually a week or two.
Now, a lot of people are motivated by the quick recovery of the anterior and the lateral approach. A lot of people are also motivated by the level of restriction in the long run. Your patients, what restrictions do they have, permanent restrictions, once they've fully recovered?
Yeah, so I used to have kind of strict restrictions, and when I just got out of training, and I've become more cavalier over the years. At this point, I don't have any restrictions for patients from day one. My only true restriction for them for the first 6 weeks is not to navigate stairs. And the
Hmm.
reason for that is conceptually, when you have a blade type stem that's wedged in the femoral canal, it it is designed to become more stable in compression. But when you navigate stairs and you bring the hip up at 90 degrees to climb up a stair, you provide a lot of torsion on the implant, and that could lead to loosening. And so I ask the patients not to navigate stairs with both legs at a time. It's okay to navigate one leg at a time, leading with a non-surgical foot, but that's my only restriction. The days, if I do your operation with the direct anterior approach, 99% of my patients, I tell them you can cross your feet, you can sleep on your side, you can sleep on your belly. If that hip is dislocating with you crossing your legs, I did something really wrong. So I don't restrict my patients anymore with that.
Ultimately, the purpose of the restrictions is to avoid dislocation, which you haven't had with the anterior approach anyway. So
Correct.
kind of the proof of the pudding is in the eating and no dislocations, right?
I mean, it can happen, and I tell patients you might be the first one. So if you don't want to poke the bear, avoid morning sunrise stretches, avoid yoga poses, avoid doing splits within the first 6 weeks after surgery while that capsule in the front is healing. So pretty much hyperextension, which most of my patients never do in the first place. And when I
Yeah,
tell people, don't do upward dog, my average patient goes, "What's upward dog?"
yeah,
Kind of dishes that. But
yeah.
but for the majority of patients, there's no restrictions.
That's awesome. That's most people's typical questions about the hip. Anything else you want to say about your approach to hip replacement before we move on to the knee?
No,
All right, awesome. Let's talk about knees. First of all, let me ask you, which do you like better, the hip, the knee, or both, as far as being a surgeon? Which would you rather do?
I think hips are naturally a little bit more rewarding because they rarely hurt after the procedure.
Yeah,
It's one of those operations where you can literally take the patient from 10 out of 10 pain, unable to take a step, to walking and smiling within 2 days. I mean, there's no other surgery like it. Maybe in the world of spine surgery, ACDF is kind of like that, where you can take the patient with a crushed nerve, take the pressure out of the nerve, and they're super happy. But I think studies show that patient satisfaction rate is the highest with those two procedures. A neck fusion or decompression of the spine and the total hip. It's just the coolest surgery to do. Knee replacement is certainly not like that. It's more like your classic surgery. And whoever tells you that they can take a knee replacement and make it not hurt, I mean, they're lying to you. There's not a single
don't
surgeon
believe
out
that.
there that can make a pain-free knee replacement. There's a little bit of pain involved with that. So hips are definitely much more rewarding in the sense that there's there's just happier patients, happier operations.
Let's talk about knee replacement. Is what's your approach and how is that different from anyone else, or anything unique about your approach to it?
Yeah, I hate to be the guy that's unique, but but yes, I again I've trained on a lot of different systems, a lot of different companies, all the major companies that produce knees. I've tried. The company that I sort of settled in is it's called Microport. It's not the biggest share of stock in the United States, but it's very popular in the Asian countries and in Europe. It's an old right medical company that got bought over, and it's one of the first companies that has come up with a medial pivot design. And so basically, in the knee replacement world, there's several types of designs for primary knee replacements. So the knees they're putting in for the first, being put in for the first time. And the two most common types are either cruciate retaining or cruciate sparing knee designs. And so basically, you have these two cruciate ligaments in the knee, and the cruciate ligaments consist of the ACL and the PCL. Those are the ligaments that the athletes tear, that you hear the football players blow out. And so in the knee replacement, you either remove both of those cruciates or you leave the posterior cruciate ligament intact. And so most of the knee designs either have a big box in the middle to replace those cruciate ligament designs, a box and a cam, which produces kind of a lot of clunking and but gives your knee stability. Or you rely on a PCL to give you that stability. And I I came from in training we used nothing but the PCL style designs because rightfully so, the PCL in a lot of patients is perfectly functional and good. But not all knees are created equal, and some knees are super arthritic. And in those knees, the PCL is not good. It's not a good structure. If you are a cruciate retaining only type surgeon, then you are relying on a structure that is, compromised in 25% of your patients, and you're not going to see the side effects of that until a few years later when the knee becomes floppy and the patient gets an anterior knee pain. So it's going to look and feel great on the table, and it's going to feel good for the first few years. And this is the patient that fails their knee replacement at year 4 or 5 when they become really active, especially if it's a young, active, athletic male. They're going to start getting anterior knee pain because that knee is not going to be stable in mid flexion. And so medial pivot knee kind of gets rid of that problem by providing a cruciate cruciate sparing design that provides a very deep dish in the middle part of your knee. And so the middle part of the knee has kind of a ball and socket almost type of congruity. So when you step on it, it becomes very stable. When you let it go, it kind of gives you some mobility. And the lateral side is kind of flat, which allows for that natural corkscrew mechanism to take place. And Microport was one of the first companies who came up with that type of knee design. And you know that something's good when every other company tries to copy it. So as soon
Yeah,
as the patent has gone out in 20 years, every single major company, whether it's Smith and Nephew, Zimmer, all of those companies have tried to copy a medial pivot design. Why would they copy something that doesn't work? Well, they copy it
right.
because it works. Now, here's the problem. The radius of curvature for the traditional type of knee design is a J curve. So you try to take a imperfect spherical knee and make it fit into a ball and socket joint. It just doesn't fit very well. So
Right.
they've tried to come up with different ways to fix their poorly designed femur and make it fit into that medial pivot design because the medial pivot design works so well. But I stuck with the original, which they're about to come up with their, I think, third generation of the evolution knee, and we're all excited about that. But that's the knee design that I use, and the advantages of it is that patients tell me that it's much more um, well fitted for the athletic type patient, the younger patient that wants to go play basketball on their knee, rather than just an 80-year-old grandma who wants to go from point A to point B. In an 80-year-old grandma, you can put whatever knee replacement you want. And if you get rid of the arthritic pain,
She's going to feel
that's going to be
better.
a happy patient. But in a
Yeah.
50-year-old who wants to go skiing next week in Vail, um, you're going to want something that's got a lot of stability, a lot of congruity, and yet gives that range of motion. And that's what a medial pivot knee design allows them to do. Now, the other thing that I do differently is I use a kinematic alignment. So basically, since the 1960s, the dogma was that you wanted to take the hip and the knee and the center of the ankle and put it in the middle line. So if you were naturally made by God or the creator or evolution, whichever way you want to look at it, to be bow-legged, or if you were created to be knock-kneed, the central dogma was we're going to make you straight. So no matter how crooked you are, we're going to make you straight. Um, and I remember learning about that and putting that into practice. And what that does is it really upsets the ligaments, your medial and lateral collateral ligaments, which we don't cut. If you make everyone who's super bow-legged or everyone who's super knock-kneed, if you make them perfectly straight, you're going to create a lot of tension on one side and a lot of laxity on the other. And so there's all these tricks and tips on how to release your ligaments and adjust the knee and balance the knee to make something fit that naturally doesn't work. Um, and the kinematic alignment sort of throws that 20 years of experience out and says, well, we're just going to make you the way you were 20 years ago. And there's different mechanisms and different tools that you can engage to achieve that. But basically, if you were really crooked now and you were a little crooked in your 20s, we're going to bring you back to where you were in your 20s. And so that's what the kinematic alignment does. And so I put in a medial pivot knee with kinematic alignment in 9 out of 10 of my patients today, and they're very happy.
That's very interesting. Speaking of muscles, as we talked in the hip, in the knee, what's your take on the muscle sparing approach with the quadricep sparing? Is that legitimate, illegitimate? What do you think?
So I think there's a little bit of marketing involved with that. I started out as a traditional midline approach, and then I've experimented with the subvastus approach, and then I kind of went back and forth with the intravastus approach. I've tried all the different approaches, and I can tell you that what works best is putting a knee in good alignment, getting rid of any osteophytes or bone spurs, making sure that the knee is well balanced, and and being able to see that. And if you can't see it, then you can't really put in a good knee. And so now I start out everybody with a kind of a mid vastus approach, which is a bit of a muscle sparing approach, trying to save that quadricep tendon. And then if I have any doubt to where I can't see or it's a tight knee or just very arthritic deformed knee, then I extend it into a traditional approach, and that's sort of been my practice.
It's kind of a game time decision.
Yeah,
Excellent. Excellent. Well, same thing if we could talk a little bit about recovery. Everybody knows the knee's harder than the hip. What
yeah.
are any tips or thoughts about to make recovery easier for patients who are going through it?
Sure. So I tell patients that recovery is a little bit multifactorial, and it depends on the patient and the surgeon. It's kind of like a couple in a marriage. You have to work together. And so the best thing that the patient can do is just follow the process. The biggest thing that's going to limit your recovery is inflammation and stiffness. And so from day two, we try to combat that. I explain the patient and kind of hold their hand through the process in that recovery journey. Elevation, icing, taking anti-inflammatory meds. My patients get about 10 different medications combating different origins of inflammation and pain.
Mm.
So these are very multimodal. It's a very multimodal approach to pain control. Um, the first week or two is a sore, swollen phase. That's where the limb swells a lot, and then the swelling kind of starts to gradually dissipate on day 8, 10. If you do what I tell you and you control your inflammation, those 8 to 10 days are just boring days with you elevating your leg a lot. If you ignore what I tell you, then you swell up a lot and you get stiff and painful. But still, by naturally, by day 10, by day 12, that knee is going to decrease in swelling and start gaining motion. Our physical therapists get you in usually within a couple of days. And by 6 weeks, most of my patients are walking without any assistive devices, without any crutches and canes. They're kind of mostly done with their physical therapy by 6 weeks. Everybody's off hard narcotic medications. Somebody may take an occasional pill here and there for therapy or at nighttime if the knee wakes them up, if they've done too much. By 3 months, most patients are ecstatic. They can return to work, even hard laboring activities like loading trucks for a living or being. I've fixed a lot of surgical techs in the hospital, so they can return back to doing that kind of thing at the hospital and standing on their legs for extended period of times. That being said, the knee's not perfect, and it takes a full year for the knee to become as good as it will be. Meaning, for all the edema, all the swelling, all the warmth to get out of it, for your maximal range of motion and strength to develop, it takes a solid 12 to 18 months. And that's consistent with the studies.
Dr. Muradov, one thing that really stands out about your practice when people look at it from a distance and people who may be considering is the extremely high patient-reported satisfaction with the practice. And those numbers often, they're certainly the surgeon, but they're also the office. Is there something about your office that makes you guys have a near perfect response from the community? What do you think that is?
Yeah, well, my office manager and is my spouse, and we kind of run a family practice, and we take care of everybody the way we would take care of a family. So
Mm.
I started off with corporate medicine, and it offers its perks. But one thing that's challenging to do in a corporate setting is to give that sort of private practice, personal feel to patients that patients love so much. Patients never feel abandoned. They never feel like they're just a number. They don't feel like they can't get a hold of you by the phone. Um, After hours, the main office line switches over to my cell phone. So if a patient needs to get a hold of me, they might have to call a couple of times if I'm really asleep, but they'll get a hold of me. And if they can't get a hold of me, they can get a hold of the office manager or the staff here in clinic when I'm operating. So that's what my practice has to offer that maybe some of the nearby hospitals can't.